residents and also junior residents during this really important period. I have no financial or relevant personal disclosures to talk about. That's not what I want. All right, so this is the agenda for what I hope we can cover today. First, we'll talk a little bit about the current training paradigm in OBGYN and some of the other surgical residencies. We'll talk about post-grad readiness in surgical trainees and the desire to establish autonomy. Then we'll talk about how we can foster proficiency and autonomy with innovative techniques. Afterwards, we'll shift to talking about being a junior faculty. We'll talk about challenges in this transition, like adjusting to a new work environment, having trainees, developing a new routine, establishing professional relationships, and asking for help. And I'll mainly be focused on talking about working in the OR, since I feel like this topic's already pretty broad and not so much on things like setting up a practice, academic or scholarly activities, establishing work-life boundaries. But obviously the transition, these transition to practice items are very broad and they're not all mutually exclusive, so they'll inevitably come up. And then we'll just finish up with a discussion about importance of mentorship and other forms of guidance during this transition and a few of the models and examples currently in the literature. These are just the learning objectives based off of the agenda that we just talked about, so I won't go into too much of details. So now that some of us are nearing graduation, I've been talking to a lot of people, from my colleagues to my other medical school friends who are in various surgical specialties. And some of us are doing fellowship, some of us are doing more research, and some people are just going out into the world and just going to start practicing. But whenever we approach this question, like, are we ready to do this? Are we ready to do surgeries? And we discuss all the different emotions that we have behind this question. Many times we feel these emotions. We're happy, we're hopeful, we're excited, or a lot of us are also scared, nervous, and anxious. And this leads us back to that question of, are we ready to practice? Are we ready to do surgeries? And before we really talk about resident preparedness to step into the OR and into a surgical practice, I think it's really important to acknowledge how the surgical landscape has really changed over the last several decades. You know, the landscape for education has changed. The way we teach is different. There's an increased awareness and quality and also in patient safety. And also there are new and innovative technologies. And lastly, how we look is also very different. So in response to the ever-changing landscape, a lot of professional societies and really smart educators have come up with ways and recommendations to move forward and ways to optimize training in order to prepare trainees for independent practice. But with the plan to prepare trainees for independent practice comes a lot of constraints from our current surgical education model. And some of the ones that I thought of were changes to the medical school experience, as board exams become pass-fail and condensing the curriculum. These potentially can affect how students may be prepared for residency. There's obviously been a huge boom in minimally invasive technologies. And with that comes learning curve for residents, for junior faculty, and also for senior surgeons to adapt to. There's been duty hour changes, as we know, and they're more strict these days, for better or worse, and we'll talk a little bit more about this. There's been increases in subspecialization and therefore multiple exposure to subspecialties. And we see this across all specialties, not just surgical ones. And therefore it makes it harder for faculty to kind of teach the broad general specialty that a lot of us sign up for, and harder for residents to gain exposure in general practice. Overall, opportunities for autonomy and independent decision-making have diminished over time. And this may be because of regulatory changes, medical legal concerns, societal and ethical changes, healthcare financing enforcements. And lastly, just about financial quality pressure. There obviously is an increased demand for surgical services, and you couple that with constraints, resource constraints and pressure to reduce healthcare costs, which then leads to more pressure on our surgical faculty to do more surgeries in less time. And this then leads to, limited time for mentoring and supervising trainees. Residents are also now dealing with a different amount of information, and you add into that the fact that more recently the pandemic has really driven up the acuity of patients that we see. In fact, according to this article, back in the 50s, medical knowledge was projected to double every 50 years. And then in this article, they said that in 2020, medical knowledge is projected to double every 73 days. Oh, and by the way, you'll see a QR code on this slide. I've made an associated QR code for each of the articles that we'll talk about today. So feel free to click into it and follow along if anything I say is interesting to you. So this is a slide that describes that delayed care from the pandemic has really driven up the overall acuity of the patients that we see. Patients now tend to be sicker than before the pandemic for the same illnesses and also for the same procedures, which they measure by case mix index for selected surgeries, including hysterectomy. They found that this increase in acuity has been the driver for increases in labor, drug, supply costs for hospital, which obviously then leads to more financial and quality demands from our faculties, which leads to less time for surgical education as residents get taken away from the OR. So, with all of these constraints, are we ready to practice? And as with all things, the answer is mixed depending on, who you ask. Within the realm of OBGYN, this question has been studied for both trainees and also for faculty. Actually, when you ask OBGYN residents or fellows, you'll get a different answer than when you ask the people who accept them. And the next few slides will go over some of these studies that address resident preparedness for fellowship and also for independent practice. This was a study of fellows from all OBGYN fellowships. And what they found was that fellows overall, like 75% of them, felt very prepared for fellowship in terms of clinical and surgical skills. Approximately 65% of them said that they were very prepared to do core surgical procedures. For Urogyn fellows, the majority felt good about independently doing abdominal hysterectomy, laparoscopy, recognizing tissue planes, lysis of adhesion, packing bowels, and a bunch of other surgical techniques. For Gynonc fellows, fewer of them reported comfort with lysis of adhesion and recognizing tissue planes, but overall as a group, they felt confidence in their surgical abilities. MFM fellows were the most confident of the cohort and said that 99% could independently do a complicated C-section, 97% could do a vacuum, and REI fellows similarly felt confidence in core procedures like laparoscopic hysterectomies and et cetera. But when you ask the people who accept them, their responses are a lot different. This is a 2015 PD survey that was published in the Green Journal, and overwhelmingly when they surveyed the PDs across all fellowships, they rated the ability of new grads and their incoming fellows to independently practice really negatively. They felt that only 20% of first-year fellows were able to independently do a vaginal hysterectomy, 46% in abdominal hysterectomy, and 34% basic hysteroscopy. More specifically from the article in their survey of PDs, 50% of incoming fellows were rated as not able to do 30 minutes of a major procedure where they're attending outside of the room. And this deficiency was seen in Gynonc, REI, and also in Urogyn. And 51% were also rated as not able to independently set up retractor or pack bowels. Gynonc and Urogyn fellows were less likely to be able to advance cases independently by the end of the first half of their fellowship compared to the other two subspecialties. And if you're interested, I would encourage you to read this paper since it also goes into their assessment of different realms like professionalism, psychomotor ability, clinical evaluation, scholarship that I won't really go into. This is a survey of Urogyn PDs and fellows. And you'll see that there's not a lot of PD second-year fellows or third-year fellows in this study, but the data is pretty representative, and it does not very representative, but it does demonstrate very similar findings to previous studies, where they showed that for the stuff that's highlighted in pink, at least, no PDs felt that their incoming fellow could suture laparoscopically. And of the people who were surveyed, 40% of PDs, 40% of second-year fellows, and 32% of third-year fellows felt that the incoming/first-year fellow could not proficiently cysto, among other surgical psychomotor skills that they looked at. They also didn't feel that they could leave their incoming fellow to operate independently on a major case for 30 minutes, or that they could do a laparoscopic hysterectomy without the attending scrub. But the second and third-year fellows did think that the first-year fellow could. Similarly, in Gynonc fellowship directors, where they looked at over 130 attendings and also fellowship PDs, they felt that approximately half of the incoming fellows could not independently do a hysterectomy, do 30 minutes of a major procedure, control bleeding, recognize anatomy and tissue planes. Now, this phenomenon is not just unique to OBGYN. This was a general surgery fellowship PD survey, where they felt that 21% of their incoming fellows were unprepared for the OR. 30% could not do a lap chole, 66% could not operate for 30 unsupervised minutes of a major procedure, among other skills. And then this study of Gen Surg residents, for residents in their last 6 months of residency, when they graded these residents by objective rating scales for core procedures, what they found was that the residents were not universally ready for independent practice on core procedures, and that autonomy for these core procedures were also limited. There was a separate survey study of 4,000 Gen Surg residents, where 27% of them said that they were concerned about doing procedures independently when they graduated, and that 63% of them were going to choose a subspecialty fellowship in order to feel ready to operate independently. And in fact, 80% of graduating gen surg residents pursue fellowship. Data from general surgery has also shown that one of the main reasons their residents pursue fellowship in minimally invasive surgery is to increase laparoscopic skills that they did not feel comfortable with when graduating residency. So what we've learned is that there's a discrepancy in the perception of the level of preparedness from residents and fellows, and also from the physicians who accept them. And what does this all mean? There are obviously a number of reasons why there can be this disconnect, but some of the reasons I can think of are differences in expectations, where trainees and attending surgeons just have different expectations about what it means to be ready to operate independently. Trainees may feel that they have the technical skills and knowledge to do surgery safely, while attending surgeons may just have higher expectations for non-technical skills, such as communication, teamwork, leadership, decision-making. There may have been limited exposure to diverse cases. Like we talked about earlier, we may not have had enough exposure to a wide variety of cases during our residency, which then makes it difficult for us to really appreciate the complexity and variability of a surgical practice, and can lead us to overestimate our ability to operate independently. Limited feedback. We may not have received enough feedback and evaluation during residency to accurately assess our preparedness for independent practice. And without regular feedback and mentorship, we develop blind spots or overconfidence in our abilities. I do think it's important for me to say that not all OBGYN or surgery graduates will face these challenges, and that residency programs obviously vary widely in our training and preparedness of the graduates. But whether graduating residents are right and that we're actually ready, or that the PDs are correct and that we're not ready, there likely is some middle ground that exists. And these differences should be bridged to ensure that we better understand our strengths and weaknesses upon graduation, and also so that we can identify areas where we need to further develop before we enter practice. So, what do we do with all of this information? And so with the rest of the time, I hope that what we can discuss is that now that some of us are almost done with residency and are going to go out into the world, what are some key components that residents can do during their latter years of training? And what are some ways that when we enter the workforce as junior surgeons, can be supported to increase our competency in the OR? Let's first talk about a surgical training model that has been shown to work. As we know, Halstead is a big figure in the history of surgery, and as important his procedures and his techniques, his model of surgical training has been seen as just as important. His model in the past was one of apprenticeship, where before him, medical school grads could either just go out and practice with what they knew, or they can enter an apprenticeship. But when he became the surgeon-in-chief at Hopkins in 1889, he organized the first surgical training program in the United States. Now, as we all know, his approach was unreasonable, since under him, trainees had to be available 24 hours a day and 7 days a week. And it was interestingly why we were called residents, because naturally it meant that we had to live in the hospital and not have as much of a life. It was also his decision when a trainee was ready for practice, and it was a decision that he made based off of his own assessment of the person's capabilities, skill, talent. And despite his unreasonable approach, a key system in kind of what he did was graduated responsibility. And under this idea is the hope that there's continued entrustment and gradual release of the learner for independent practice in the OR. And this approach has been shown to be effective in improving trainee performance and confidence in the operating room. Faculty entrusting a resident to do a surgery or care for a patient essentially means implicit and explicit statement that the faculty trusts the person to do this task independently. So how do we gain this trust and independence from our faculty to do things in our latter years? Some ways are potentially refocusing the curriculum to have increased use of simulation, competency-based assessment and advancements, and more robust operative skill assessment. Regarding simulations and assessment of operative skills, within OBGYN, we have the opportunity to do FLS. As a way to assess our operative skills, we also have the new EMICS curriculum. This gives us some confidence to perform similar procedures in the real world. We also regularly have simulations, as we know, to keep up our knowledge and skills. And competency-based assessments are also important, since the literature describes the need for training in non-technical skills as well. Since a surgeon is not just technically competent, he or she also needs to have effective communication, teamwork, and leadership to have a successful surgical practice. Now about the last point, for being intentional and having innovative approaches to offer senior residents autonomy and independence. I think this is where innovative approaches to giving residents autonomy and independence come into play. And before I really address this quote, I just want to talk about duty hour restrictions. Some people have in the literature said that the current residency model, which has been described as T-steeping, or like 10,000 hours of doing something, are in danger of amounting to a lot of weak T, or 10,000 hours of doing something minimally well by restricting hours. But is the answer really just to have longer training? Which probably not. It's probably not just a longer training. Instead, the ultimate goal should be to have autonomy in the OR as trainees and to learn to practice independently. And I like this quote from Henry Ford because I think it's a good thought about how you just got to think outside of the box. And simply adding time and not having the chance from faculty to proceed to independence in the OR and then perioperative decision-making likely won't lead to significant improvement in the OR with just adding time. And beyond just surgical techniques, like we said, there are a lot of non-surgical techniques as well that we need to learn from doing or learn from our surgical teachers that underpin our surgical performance. So what are some known ways to practice this graduated responsibility and earn independence in the technical and non-technical aspects? One intentional, innovative entrustment approach was published here from the University of Florida's neurosurgery program. This program actually changed its curriculum in 2004 to make their PGY6 the chief resident and their PGY7 the last year resident as junior faculty. And this junior faculty is then responsible for developing, implementing, and managing a schedule like a junior faculty would. And that each junior faculty resident then had their own designated OR day each week, and they made independent decisions regarding perioperative patient care. Each of the cases that they took to the OR was reviewed by a faculty mentor pre-op, and the faculty mentor then was available to help in the OR. And post-op patients, they made independent perioperative decision care, and each of the post-op patient was then presented at a bi-weekly case conference with all of the attendings so that they could develop a sense of autonomy. Over the 8 years, this was published in 2012, they had 8 junior faculty residents and they logged about 1,800 cases independently, one logging about 400, which they responded was consistent with what someone could expect in a general neurosurgery practice. So, obviously great, you have autonomy, but the next question is this even safe to do? This was a study that was published just recently in JAMA Surgery in February. They studied the level of autonomy provided to residents during their training, trends in resident independence over time, and association between resident independence in the operating room and their clinical outcomes. They used a VA Surgical Quality Improvement Program database over the last 16 years, and they compared procedures where the faculty was scrubbed in versus the faculty not scrubbed in. They included only the last 3 years of general surgery residents, so like the 5th, 6th, and 7th year for a 7-year program. And they looked at 5 procedures that are listed here, where they felt that the residents should be comfortable doing by the time they graduate. And each of them had a slightly higher potential for postoperative complication with an established benchmark for what an acceptable rate of complication should be, so that they could compare to see if there's a higher risk with either group. And this picture here just shows that the cases performed with attending not scrubbed in has decreased markedly over the period of study over the 16 years across all of the procedure types. And after they adjusted for patient characteristics and other operative factors that would be expected to be associated with clinical outcome, they found that the group with the attending not scrubbed in into the cases was associated with a very small increased likelihood of post-op complication. But actually, when you model out each of the cases individually, there was no notable association between the level of resident independence and the likelihood of a postoperative complication in any of the 5 procedures. And on their univariate analysis, they also didn't find any differences in complication, severe complication, or death. And my purpose here is to just show that transition from surgical training to surgical practice just needs to be supported through effective educational interventions and probably also have buy-in from faculty so that we can ensure a safe and supervised environment to support autonomy. And that we all just need to be aware of some of these challenges and have intentional ways to provide trainees with support and resources needed to develop skills and confidence for a successful practice. Another example from GenSurg is this program, what used to be called the Transitions to Practice program in GenSurg, now called Mastery in General Surgery. It was formed in 2012 after they had a concerning survey from about resident preparedness, and the American College of Surgeons then led a conference that was attended by leaders from certifying boards, PDs, professional societies, so 12 different surgical specialties, Joint Commission, US military, and a bunch of other people. And the result was to develop this program, the TTP. Essentially what this did was that it took someone who recently graduated from residency They put them in an autonomous experience with a mentor, like an auditioning experience, and gave them experience that were probably not available in residency, like having independence in the OR and office, and giving them appropriate mentorship for what a broad-based general surgery practice would look like. A lot of the people they found who did this program were people who wanted more broad-based general surgery experience in recent grads who couldn't find a suitable job, or that practicing surgeons who wanted to have a re-entry into general surgery. In 2013, they only had 2 sites, and now they have this many approved sites. And the idea here is that this wasn't a fellowship, but just a way for people to earn additional surgical techniques, and that is important for a broad general surgery practice. But this kind of thing is obviously not for everyone, because for some, the thought of just doing additional training to be a broad-based general surgeon or a general OBGYN seems counterintuitive. And the goal, and it should be the goal, that a progressive autonomy can be achieved in residency through simulation, procedures, competency procedure-based evaluation, and intentional autonomy exposures, that programs like this may not be necessary. These are some examples from OBGYN, and not necessarily training programs like we just talked about, but initiatives taken by ACOG and CREOG to prepare trainees for surgical practice. There's the surgical curriculum that was established by the CREOG Surgical Skills Task Force to develop and implement a standardized curriculum for surgical skills. The ACOG Practice Management Curriculum that teaches faculty development. And as we know, the Fellowship in Minimally Invasive Gynecologic Surgery that was developed to address the concern that most graduating residents may not have been fully trained in modern endoscopic surgery. There are also some surgical education workshops for fellows to increase surgical skills. An example from OGS to ensure that trainees continue to stay proficient in their surgical skills. So, enough talk about the training period, and some of us only have exactly 30 weekdays left of work and a few call shifts. So, now what? Does it mean that's too late for us? And what if we don't want to go through additional training? And how can we ensure success in the OR now? As we know, graduates from surgical residencies and fellowships will always require a period of time of adjustment as we transfer from trainees to surgeons. And even though surgical residencies attempt to prepare residents for transitioning to attendings, the changing of role obviously is still really daunting. We'll find ourselves fully responsible and also needing to educate learners. Depending on where we were trained, this could be the first time that we have complete independence in the OR without somebody else present. We could also be asked to do unfamiliar cases or complex cases for the first time without a teaching faculty across the table. Studies have shown that the first 1 to 2 years after training have lasting impact and influence on the long-term success of the new attending. In this study by Stolarski and colleagues from 2021, where they evaluated what challenges young surgeons can face, 28% described that their transition to practice experience was very poor, or acceptable, and 58% said that they had at least some institutional support. The most commonly reported challenge was trying to build confidence in the OR as an independent surgeon, followed by adjusting to a new culture. And all of this to say that the transformation of a surgeon from a chief resident or a subspecialty fellow to an attending doesn't take place throughout a single day, nor does it occur without considerable effort on the part of the new surgeon or interested colleagues in the institution. And one of the new challenges to get adapted to as we try to build confidence in the OR is inevitably in how we teach. In an exploratory survey of surgeons, when they asked about the most challenging teaching setting, not surprisingly, they selected the OR as the most challenging setting by both early career and also by experienced surgeons. And the transition to a surgical educator is challenging no matter how well trained a resident or a fellow is upon graduating. And trainees whose job it was just to operate a couple of months ago and learn just a couple of months ago will now find themselves responsible for their own patients while simultaneously trying to educate other residents as an academic surgeon. And speaking as a resident, we obviously also have a lot of respect and expectations from our attending surgeons, like excellent patient care, a desire to have focused intra-op learning, and hope that the faculty will have patience to let us problem solve and grant us some autonomy. This was a 2022 needs assessment survey of surgeons where they just tried to understand the challenges that in trainee education in the OR for new faculty compared to older faculty. And the survey found that the majority of respondents used one or more structured educational strategies, but less than 1/3 of them were formally taught on how to teach in the OR. And approximately 75% of them said that they were struggling in their new role as an intraoperative educator. Most faculty struggled with balancing delivering good care while also providing autonomy and growth for the residents. And I just want to spend a moment to clarify or identify some major themes about why it can be challenging. In terms of the biggest part of this graph, relationships, most found that developing significant relationships with learners was hard because oftentimes their rotations were short, and a lot of time faculty have really fragmented exposure to work with specific residents. So it was hard for them to really develop trust in the resident and know what the resident is capable of, which then obviously leads to divergent expectations between the faculty and the resident. With ongoing learning, the junior faculty talked about feelings that they must expand and solidify their own knowledge and skill once they complete training in order to feel that they can handle any situation that comes up. But this often made the residents feel like that they were taking the case away. With systems-based challenges, they talked about difficulty relating to balancing OR efficiency, patient safety, how the resident was completing the task, the time it took them to complete the task, and things like that. Cognitive load relates to issues of having a lot of learners like med students, residents, fellows, scrub techs, new nurses, and things like that, and also trying to identify opportunities for all these different multiple levels of learner and making time to do that. And lastly, image management was the challenge that faculty were worried about their evaluations or being perceived as less capable or less confident by the residents. I do think that going over the different ways and recommendations from the literature to do effective inter-op teaching is outside the scope of my grand rounds. So I wanted to link this resource. This is a really short read where the author of this article talks about a framework for our faculty to effectively grant more autonomy to residents and setting them expectations in an upcoming case or a structure to guide their behaviors. But beyond just having tips for individuals aside on how to teach in the OR, many sources cite that one of the most important ways to move forward is to have organizational support for the junior faculty when teaching residents earlier in practice, like having formal mentoring programs or to better prepare trainees or junior surgeons for the transition from trainees to new surgeons and new educator. So next, to help with these transitions and more, young surgeons should be paired with a senior for mentorship. But what is mentorship and who are mentors? Last week, Dr. Neil Perry talked about the importance of mentorship, so I hope to kind of explore this a little bit as well. Mentorship, as we know, is a nuanced term and a very complicated term, and our role as mentee in this relationship can be just as important, so I'll talk about that. The concept of mentorship can be traced back to ancient Greece, where the word mentor comes from the character of Mentor in Homer's epic poem, The Odyssey. The mentor was a wise and trusted friend of Odysseus who was entrusted to take care of his son while Odysseus was away at the Trojan War. And the character of mentor actually came back as a symbol of wisdom and guidance in Greek literature. Mentorship is a personal and developmental relationship where an experienced and knowledgeable person, where the mentor, provides guidance, support, and advice to a less experienced person like the mentee to help them achieve their personal and professional goals. The mentor is a role model, gives feedback, shares knowledge and experience, and helps mentee develop skills and competencies. And these are some pictures off the Whisk OBGYN Instagram. So, if you want to be on this slide, then we'll need to increase your social media presence. Mentorship in surgery is a key in success for a department, and the success of a department is often measured by how the program cultivates and supports its young surgeons. There are many types of mentors and many ways that you can have mentoring. In surgery, the most common area of mentorship was intraoperative coaching for junior surgeons, along with other areas of mentoring. And successful mentoring, as we know, is helpful for career development, but can also be helpful to have just a successful role model, promoting empowerment and confidence, and can encourage academic craftsmanship and proficiency in research and have a higher job satisfaction. As we know, the attrition rate for a surgeon's first job can be as high as 30 to 50% in the first 3 years, but having good mentorship relationships could potentially decrease this. For surgical success, having a surgical mentor allows for prospective discussion of cases, retrospective feedback about operative performance, and assistance with critical intra-op decision-making. This was a survey study of colorectal surgeons in their first couple of years of practice, where they emphasized that mentorship was one of the key important strategies towards career progression. Additionally, many career surgeons, also early career surgeons, found that not having a mentor was a big barrier to success as a career early surgeon. But 1/3 of survey respondents said that they lacked any form of mentoring when they first started practice. And the fact that almost 1/3 of people lacked mentoring where they first started is in line with other literature that shows inadequate mentorship of junior surgeons in academic and private practices. There was a survey of surgery department chairs where they found that only half of surgery departments in the US have established mentorship program, with 1/3 of them lacking formal or informal mentoring. There was a survey of members of the Southeastern Surgical Congress, where 25% of people, newly trained surgeons, said that they did not receive any help from associates during their first couple of years of practice. An ACS survey found that younger surgeons only had senior partners assisting on 9% of their cases in their first year. So we know that mentorship is important, but where do they come from? They can come from inside or outside of the institution. Within the institution, they most often come from senior colleagues, and having these senior colleagues, especially from the same institution, means that they could potentially scrub on complex procedures. They have knowledge of local resources, the culture, the environment, as well as relationship with other faculty and staff. They also have a greater vested interest in supporting the junior faculty from the same institution. In the real world, I learned that Kaiser San Diego assigns a new surgeon to act as a first assist for senior surgeons, and senior surgeons often scrub with new surgeons during their first 6 months. For Gunderson and La Crosse and Geisinger in Pennsylvania, new surgeons are assigned a senior mentor who provides guidance in establishing a new practice and are available to scrub on more complex procedures or provide intra-op consults. Next, we'll talk about retired surgeons. So retired mentors. The benefit of having a retired surgical mentor is that you alleviate stress on senior surgeons. And nearly 50% of young surgeons within 5 years from completion said that they're willing to be mentored by a retired surgeon, and even a lot of surgeons who are 5 years and older. Retired surgeons obviously have a lot of clinical experience. They have pattern recognition, reasoning abilities, and a lot of community and professional connections. But do they want us? In the survey study of retired surgeons, they found that retired surgeons have actually been involved in a lot of things like tumor board, M&M, sim training, mock oral exams, problem-based learning. And over 50% of a survey of retired mentors said that they want to mentor recently trained surgeons. Many retired surgeons said that they haven't actually been able to find any teaching or mentoring opportunities despite frequently reaching out to medical schools or residency programs. And there was one quote from a retired female surgeon that said, "After retirement, it was a shock to me that people did not want my advice, even for free." And for free, it's true. 82% or over 700 people, retired surgeons, said that they were willing to mentor new surgeons for free. From outside of the institution, you have past mentors from residency. You also have professional societies who play a really key role in establishing mentors or meeting mentors at society meetings. This is an example on the ACOG website that advertises its mentorship program, which they make available to new surgeons, junior fellows, med students. So, if anyone has tried this, let me know. There are a lot of different approaches where you can connect with your mentees, and mentorship, as we know, can be informal or they can be formal. Informal mentoring can be rewarding because it allows for more open communication, but it can be harder to kind of standardize, monitor, evaluate. And there's intraoperative coaching like we talked about. There are roles for new technologies like video conferencing, phone talks. There's obviously also legal, ethical, licensing, credentialing issues. But for people who practice in rural locations or have solo practices, phone calls to residency teaching faculty can be very valuable resources to discuss difficult patients. But having hands-on surgical OR mentorship can be a little bit harder because of the practice setting. So in these locations, young surgeons can consider relying on more experienced people in their area to scrub on complex cases, but these are also settings where retired or part-time mentors can be particularly helpful. Regarding barriers to getting mentor, the single most significant barrier across all of literature that I read was a lack of time for both the mentor and the mentee, given the demands of a surgical practice. Some other barriers are perceived or real competition for patients by these mentors, lack of available mentors, regulatory and financial concerns, a concern about a risk to the reputation of the mentor if the mentee is not able to meet the expectations. And sometimes new surgeons may also be reluctant to ask for help in the OR because of some stigma in asking for help. And in order to destigmatize this article actually writes really nicely about how it's okay to ask for help in the OR. As we know, transition to practice is not just the long anticipated application of a junior surgeon's skill and knowledge, but also comes with, as we know and shown in the literature, an increased risk for surgical complications and adverse outcomes. Some reasons why juniors may not have as much help in the OR include changes in the surgical environment, like work RVU-driven contracts and changing practice patterns. Junior surgeons may not want to be interpreted as weak, sacrificing autonomy. They may not want to cause financial and work burdens on senior colleagues, and then they may not want to cause role confusion where you may not be seen as the main surgeon. Senior surgeons similarly may be hesitant to step in because of fear of undermining the junior surgeon's confidence or causing them to lose face. But really, the literature supports developing a system that fosters effective faculty mentoring to give support and insight. Some examples to fix this, according to this article, are structured way for the juniors to allow access to senior surgeons in advance of intraoperative difficulties, having a culture of an open OR, and increasing workforce diversity. For financial reasons, they talked about how the department could give full work RVUs for the co-surgeons if they mentor the junior faculty. They also talked about their own experience with a pilot program of 3 years for 4 junior faculty surgeons, where surgeons in their first 3 years could request at will for elective and emergent cases help from the senior partners. And they gave full work RVU credits for both the primary junior surgeon and also for the senior surgeon who supported them. And over the 3 years, they found that the 4 juniors requested help from the seniors in 265 cases, and that the seniors were able to develop plans, remediation plans, when they identified deficiencies in decision-making, and that they had also asked for the junior to co-scrub on 73 of their own cases so that they could build operative experience for the juniors. Now that we've talked so much about the importance of having a mentor, I think it's important to talk about how this is a two-way street. First, successful mentors are set up often in a structured manner, and both the mentor and the mentee should have really clear expectations about their goals, needs, expectations. Otherwise, you risk having an ineffective relationship. This is a great article from the Harvard Business Review that highlights this relationship. It describes this relationship as like a tango between the junior and the senior surgeons, and they provide an outline for 5 habits of what an ideal mentee could look like. Like we talked about before, ineffective mentoring can lead to junior surgeon attrition, them not doing academic practice, decreased productivity, career satisfaction, and limiting career development. In general, a good mentee is someone who is results-centered, someone who considers the whole organization instead of themselves, someone who's internally directed but open to critique. And lastly, knowing that you drive the ship and that you have to devote time to make it work, because the mentor shouldn't be someone to spoon feed you, but someone to guide you through your plans. Now, to just briefly touch on intraoperative coaching. As we all know, athletes use coaches to improve performance, especially the most elite of athletes. And coaches identify areas of improvement followed by deliberate practice. This is not as well used in medicine and often leads to surgeons to plateau in their skills and efficiency. And I won't go into extensive detail about coaching because it has been covered in a separate grand rounds by Dr. Gross. But in this article, Atul Gawande talks about how it dawned on him one day that he would gladly ask for a coach on his tennis serve, but the idea of doing the same for his surgical performance was almost inconceivable. But then he talked about how he subsequently invited a retired mentor to come and observe his surgery to become his surgical coach. And the coach was invited to go to his procedures, make observations, and to Atul Gawande's initial consternation at the end of a really smooth procedure, he found that the coach made a bunch of observations, a bunch of notes. But then he found that he and his coach would get together, look over videotapes, freeze frame, discuss highlights just like a sports team would. And the coach helped him identify areas of improvement, set goals to analyze his progress during the next couple of sessions. Mentoring, coaching, role modeling, teaching, they're all different strategies where one or more person can help another person. But there are, although there are similarities between a coach and a mentor, there are differences where mentorship is kind of this unidirectional advisory or counseling role of a senior surgeon towards a junior one, like preoperative review of things to try in surgery or intraoperative consults. Whereas coaching is more kind of like immediate feedback of observed behaviors, challenging those observations and facilitating the development of some new behavior. And this approach is often done during surgery or like a debriefing after surgery, and involves a reflection, constructive feedback, and emphasizing positive performance. And again, if you're interested, you can listen to Dr. Gross's grand rounds that summarizes coaching and resources for that. Now, we're almost done, but we can't discuss mentorship in surgery and medicine in general without discussing that certain groups may feel less empowered to ask for help, such as women surgeons and surgeons from underrepresented group. Gender represents a potential barrier to mentorship of junior surgeons. And the Me Too movement has raised awareness of sexual harassment, violence, and discrimination in our workforce. And one concerning aspect when we talk about mentorship for women is the potential impact the Me Too movement has on men's willingness to mentor and sponsor women. Recent articles from both JAMA and the New England Journal of Medicine have raised this question. They said that denying women access to mentorship and sponsorship perpetuates a gender gap which needs to be closed. Now, there is concern that being afraid to mentor women is not only about fearing false accusations of sexual misconduct, but also discrediting women who speak out against harassment. Over the past few years, as we know, race has also come to the forefront of our national attention, and people may not be as confident in asking for help because there may not be a lot of people who look like them. They may not want to confirm negative or untrue stereotypes or fear that they may suffer microaggressions and etc. In medicine, there's no denying that surgery is still male dominated and that there's a striking lack of diversity in the physician workforce. And overall, women surgeons and surgeons in underrepresented groups experience greater challenges in procuring effective mentorship, and that does remain a key factor that limits career progression. Studies have found that well-organized programs help bridge this disparity, and that changes brought about by mentoring of women surgeons and surgeons in underrepresented groups can be sustained. But beyond that, there should just always be a culture of openness and communication with attention paid to creating a more inclusive and supportive work environment. So in conclusion, we've talked about a lot and we talked about all of the above. But lastly, I just want to emphasize that all of the literature I read stressed that being a great surgeon is not just about skill, but also about good judgment, recognizing limitations, and knowing when to ask for help. To be skilled and confident when we first start practice often requires significant efforts on our part as residents to earn that trust from our faculty to work autonomously and to also have buy-in from our attendings to have that type of graduated responsibilities to advance. But regardless of how well trained we are and how lucky we are to have graduated from a program like this, over the first few years will undoubtedly be really challenging. And mentorship is crucial for our success as a junior surgeon. And from personal and institutional standpoints, we should have established systems in place for effective mentor-mentee relationships, destigmatize asking for help, recognize contribution of gender and minority representation in surgical mentorships. And that's all, folks. Thank you. Yeah, Catherine. Yeah, I think that's a really complicated question. I didn't specifically look into graduate autonomy as it relates to gender, but obviously there could be some underlying, and it just requires some multifaceted approach and just a kind of institutional culture of openness and having, some training on conscious biases and things like that. But I didn't specifically look at that. Dr. Lepic, yeah.
Really great job.
I didn't actually find any data for general OBGYNs. I think it was probably hard for them to survey, when they went out to multiple kind of different settings for jobs. So a lot of the data comes from fellowship directors because it's a little bit easier to sample. But from general surgery literature, if we can borrow from that, they do find that general surgeons who graduate and do general practice in the initial couple of years seem to, need some mentorship and guidance. Yeah, Aaron. Yeah. Yeah, for sure. Actually, really interestingly, and maybe encouragingly, is that across, I'm just not gonna do that. Across all of those literature where they looked at fellowship incoming fellows, at the end of the fellowship, like 88 to 90% of them would all agree that they were ready for independent practice. Yes, Dr. Brown. Thank you. Thank you.
You're about to cut into the earth. And so it is it's something that you don't recognize is actually okay and have the ability to do that mentoring where there's actually have some of that built in. I will go out into practice, colleagues for opportunities. That's really helpful. I almost just showed up in the room because I was like a young female and I didn't want to look like I wasn't confident, but like I've never been so relieved to be like, oh, there's someone here who knows more than I do. So you hit it out of the park and you can all learn from it, but also as more senior person, remember that feeling for your.
I think wrap it up here with one question online from
Dr. Rose says, why do you think we are so reluctant to engage retired surgeons? Yeah, and I don't know exactly why we would be so reluctant to engage our retired surgeons, because obviously they, like we talked about, have a lot to offer. So I didn't look specifically why we would be so reluctant, but they are a great resource.